Good evening, everyone. We now begin the session on molecular genetics of inherited diseases. Please join me in welcoming our chairs, Dr. Vinod Skaria, Chief Data Officer, Karkinos Healthcare Private Limited, Bengaluru, Dr. Alan Matthew Punnus, Associate Professor, Center for Regenerative Medicine and Stem Cell Research, Sri Ramachandra Institute of Higher Education and Research, Chennai.
She does not need an introduction in here, but she's a well-known figure in genetics in the country with significant contributions into a variety of diseases in terms of gene discovery, in terms of registry creation, and of course, in terms of clinical trials. So she's going to talk today on deciphering the omics for Alkaptonuria. Stage is all yours.
A very good afternoon, and after the lunch probably you will be very sleepy. So I'm going to tell you like a story to help you make your sleep better. So I thank the organizers, Dr. Nihal and all the entire stem cell team and Dr. Srijan for this opportunity. I will be telling you how to explore the genetic metabolic pathways to unlock the mysteries of a really rare inherited disorder, that is Alkaptonuria. So this is a story where we have a remarkable discovery beginning in a marginalized indigenous community in Tamil Nadu. As you can see that this community are generally selling beads. They are the bead sellers. They are a nomadic people or gypsies, as you would call them. And this story would reveal insights into one of the medicine's oldest known genetic disorder. And behind this is Dr. Isaac Jaberaj, who was a former orthopedics surgeon in CMC, and he is the physician whose curiosity transformed the clinical observation into groundbreaking research. So as he worked as a missionary doctor in this community, so he made three critical observations. One was this is a genetic isolation because it's a marginalized indigenous community in Tamil Nadu with strictly endogamous marriage practices, and therefore it created a closed genetic pool. And there was a consistent pattern where males over 30 years generally would develop severe back pain and progressive spinal stiffness with large joint involvement. This was a community-wide impact because the prevalence suggested that probably it could be a hereditary condition which is passing through generations within this isolated population. So as he was a doctor and service with a mission, so the immediate clinical goals were the pain management. So he used to give them the pain treatment for alleviation of the pain. But he being an orthopedic surgeon, he would bring them for joint replacement surgery for mobility restoration and community upliftment through comprehensive care. But above all, there was a deep curiosity to understand both the community's unique heritage and the underlying disease mechanisms which are driving their suffering. So as in the morning also Dr. Gokhale said that we see the suffering of the patient as doctors, and then we start research with a curious mind. So the joint problems were a diagnostic journey, and initially it looked those with a stiff back and a stooped posture to having a sort of a rheumatic disorder called ankylosing spondylitis, and therefore it was consulted with the rheumatologist, and the major marker for ankylosing spondylitis is HLA B27 association. So this was the first test that the community underwent, and as you can understand that it was negative in for this genotype. But at the same time, there were some unexpected clues, which was like the staining of the diapers in the infancy, black marks on the clothings, and urine testing showed that it turned black when ferric chloride was added. So this was my husband's observation, who was an astute clinician. And we came closer to the diagnosis, and wherebit we could see that it is a monogenic disorder called Alkaptonuria, and I was involved in that. So it is not a new condition. It has been described in an Egyptian mummy called Harwa, and in that the X-rays which were subsequently done here was published in Lancet, and it is one of the oldest documented genetic condition with evidence extending in millions of years ago. So as the genetic disorder was evaluated, and we could project it through Dr. Isaac and his team of other members who were in the UK, Dr. Ranganath, and the society chief, Alkaptonuria society chief at that time, Nick, and the people who were affected, and also Professor S.S. Agarwal, who was my mentor for medical genetics. So this Alkaptonuria is a clinical triad, and it is one of the earliest described inborn errors of metabolism. And this triad, as you know, it is a metabolic disorder, and most of the inherited metabolic disorders are autosomal recessive, and there were the deficiency of the enzyme, that is homogentisate 1,2-D oxygenase, which leads to accumulation of homogentisic acid in the blood and also in the connective tissue. So as a result of excess of it in the blood, ultimately it has to go through the urine. So the dark urine is the earliest sign, and it presents from infancy. So the urine will darken upon standing or upon alkalinization. Then this pigment is going to deposit in the connective tissue, and it is called ochronosis, where it is visible in the sclera, the ear cartilage, skin, and typically it manifests in the 3rd decade. So although the problem is present by birth, but the manifestation starts later on, at the later stage, and this deposition gradually leads to the progressive degenerative joint disease of the large joint and spine, and causing significant morbidity. So as you can see in this picture, that the urine will turn dark on standing, the sclera will be pigmented, sometimes teeth and gums will be, the ear here you can see there are stones of prostate or the kidney, and often they will have weakness of the tendons and the ligaments to the point that they will rupture. So when a surgeon operates, you can see this black deposits which are seen here in the cartilage and the connective tissue, and then the rigidity of the spine, and also you can see the pigmentation of the skin. So as I mentioned, that it is because of the deficiency of the enzyme, and it is coded by the gene, the HGA gene, and it is it disrupts the tyrosine metabolism, and thereby the tissue is weakened because of this deposition. So understanding AKU's pathophysiology often offers crucial lessons for developing therapies for osteoarthritis and related condition, because here the arthropathy sets in very early. Even in young age you look like a 60-year-old or a 70-year-old man. So this was published in 2021, and the actual pathway is in the tyrosine metabolism, where the metabolism of tyrosine, it degrades and it gives rise to fumarate and acetoacetate through the various steps, and it is here that when this enzyme is missing, the substrate, that is homogentisic acid, will keep on accumulating, and it will come in the circulation, thereby it will bind and disrupt the collagen and cause pigment and severe osteoarthropathy. So because there are high levels of HGA, the urine in normal person, it is undetectable, but in patients of Alkaptonuria, it can go up to 100 folds, and there can be an excretion of 1 to 8 grams daily. So that was the primary effect. But as you know, a genetic disorder affects the entire cellular metabolism. So there are some secondary effects which can happen, which will be due to the oxidative damage, or there can be release of the pro-inflammatory cytokines, or there is a dysregulated redox homeostasis leading to mitochondrial dysfunction, and overall there is increased osteoporosis or osteopenia through the rank L and the decreased levels of autoprogerin. So as I told, the timeline of symptoms is there in the infancy as the stained urine, dark stained urine, but and typically childhood they are asymptomatic, but there is continued HGA accumulation, and by 20 to 30 years the cartilage becomes and the sclera become deposited, and it is visible by the eye, and then beyond 30 years there is debilitating arthropathy affecting spine and joint, and severe mobility limitations requiring surgical intervention. So therefore early diagnosis and monitoring is important. Dr. Vinod has already told that it can be included, such diseases can be included in newborn screening. This is autosomal recessive disorder, and the genetic counseling essentials, which we all know that there will be a 25% risk of affected child homozygous, or there may be 50% carriers heterozygous, and unaffected homozygous non-carriers as well. So consanguinity significantly increases the risk, and populations especially with high carrier frequencies. So what is the prevalence or the global prevalence? It is a very rare disease worldwide, but the prevalence also varies across different populations due to founder effects and genetic drift. Therefore, it is important to understand the regional variation. So if you see here, globally it is 1 in 100,000 to 250,000. But in certain regions, like as the Slovakia and Dominican Republic, it can be 1 in 19,000. So what does this imply? That in high prevalence population, neonatal screening programs and carrier testing may be cost effective public health interventions. So this was an ICMR study which we had conducted in our department, and there were several districts of Tamil Nadu which were involved in this study, and we had to reach out to the community to detect them and see that they had this urine screening positivity. So about, this was an ICMR funded, and this reflects actually that the founder effects which were present in this population and with high rates of consanguineous or endogamy, and the ethnic specificity screening, genetic screening programs may be applicable. So this was a large family, as you know that they are endogamous, so multiple affected members, which gives, for an autosomal recessive disorder, it may look like a pseudo-dominant or an autosomal dominant disease because of the high prevalence of the carriers in that population. So this was the ochronatic pigmentation, which you can see here in the lady who is around 40 years of age, and these are the characteristic symptoms, like that is the scleral pigmentation, the ear cartilage, nasal cartilage, and tendon and ligaments sometimes. So it becomes apparent in the third decade, and as it continues, it causes the morbidity. So again, here there was a community work outreach program where we could screen these people. So around 499 people were screened with a simple urine test, which is by alkali, adding the alkali, and you see the change in the color. And there was 42 individuals who were tested positive, and this gave a high prevalence of 8.4%, and approximately, which is 400-fold higher. So this was published, and these are the main symptoms which were occurring in this population. So the founder effect combined with endogamy creates ideal conditions for recessive disease clustering in isolated population, and therefore we can sensitize them, make them aware, and do a targeted screening for early diagnosis, genetic counseling, management, and monitoring. So the founder mutation, of course, is a splice variant. We also found other mutations in the rest of the Indian population as people started sending from all over India. So, and there was 4 novel pathogenic variants as well. So finally we had to do a functional study for the founder effect, for the founder mutation, and this was through another DST grant which was done by Sunita, and we had the opportunity to check a homogeneous population of 30 individuals with this homozygous mutation, and also in heterozygotes. So a real-time PCR was done, and the different peaks, as you can see, for the heterozygotes, homozygotes, and the normal population, which was subsequently amplified with the cDNA and a PCR. And the relative gene expression could be seen, and as the age evolves, you can see the expression is getting reduced. And also the HGA levels in the plasma were checked, and it showed a good correlation with the age. So finally, when the cDNA would be sequenced, you could see that there was a total skipping of exon 2, and being a splice mutation, this led to the abnormal protein, and it could be compared with the normal individuals. Finally, computational modeling was done by MissSense 3D software, and the commonest pathogenic variant which was found in rest of the population, which showed that there are structural damages. So this variant is also found to the maximum extent in Jordanian population, and this helps us to screen for the hotspot so that we can detect Alkaptonuria by a cost-effective method. So these were the other variants where structural damages could be seen, and you have the protein backbone flexibility which is hampered, and there were some where there were no structural damages seen, but there was a arginine where the charge changed, and to glutamine which is uncharged, and therefore which can affect the protein stability. So here again the protein folding, stability, and the hampering could happen without any structural change. So in the novel variants we did, and although we didn't find the structural changes, but there were the side chain, the function was defective with the polarity, the side chain groups, and the intermolecular forces, which made it a likely pathogenic variant. Now all this is done why? So that we can detect and treat early. So till now there was just symptom based intervention, but there has been remarkable repurposing of a drug called nitisinone, which is used for hereditary tyrosinemia type 1, and this is actually obtained from a very native plant which is called the bottle brush plant, and because this was a patented drug and it was produced outside, after the patent finished, then the companies in India started making drugs for rare disease, and therefore the cost of nitisinone came down from 1 lakh per month in 2020 to 10,000 per month in 2023, because it was being manufactured here. But still there are certain ifs and buts for the treatment by nitisinone. So it reduces the homogenesic acid excretion, and but there would be a development of hypertyrosinemia because you are reducing the substrate, and the tyrosine level can go up. And we don't know till how long it is going to continue reducing, and whether it can be started in childhood or you have to wait for adulthood, and where there will be side effect to prevent the side effects. So this is actually an inhibitor of the 4-hydroxyphenyl pyruvate deoxygenase enzyme, which is the converting enzyme for homogentisate. And once this is blocked, then you don't have the substrate, and thereby the effects of the disease are reduced. So finally, there was an FDA approval, and lot of trials outside in the UK were carried out. They were the SONIA 1 and SONIA 2 trial, in which different doses of nitisinone was used. However, it is still was not certain for Indian patients, because it was not being used because of the cost, and we don't know what was the optimum dose. So we got an ICMR grant for studying and comparing the dosage of 2 and 5 mg once daily for nitisinone as a double-blind randomized controlled trial. And so just to tell you, it is not yet complete, and we have some preliminary data where both are effectively reducing the HGA levels on a 6 months follow-up. We have, this is the data of the open labeled of 25 patients. Now we have 30 patients who are still there, and there are some biomarkers also which are being studied, and nitisinone seems to reduce the inflammation by, as you can see, by the ratio of Rankel and the osteoprotegerin. And there was some improvement in the severity, which is done by the AQC score or the Alkaptonuria severity score in the 5 mg group. However, this is all preliminary data, and we will have to wait for the final results. And apart from ICMR, the drug was provided by Intas company. So what is the way ahead for improved management? We may have to still have scope to make ASOs, that is the oligonucleotides, or gene editing tool, and also to target the secondary effects such as oxidation, osteoblastic activity, and mitochondrial dysfunction. And above all, supportive management is very important, such as the diet, physiotherapy, and lifestyle. So there is a special diet which has to be included so that you can have decreased level of tyrosine, because that is a side effect, and we may have to supplement with tyrose-free protein powder. Of course, lifestyle modifications and different meditations and the biofeedback mechanisms to decrease the pain have to be implemented along with it. So as you know, there is a national policy for rare disease where the government is divided the inherited disorders into 3 groups. Group 1, where they are amenable to organ transplant or bone marrow transplant, and government provides funding up to 50 lakhs, and there is a limited list of disease. However, I am happy to tell you that Alkaptonuria got approval just last month to be included in the National Rare Disease Policy, so that they can benefit the patients. So out of the rare diseases, about 80% of them are genetic, and I am happy to include Alkaptonuria also in this list. So acknowledgement to my entire team, and all the patients who have cooperated, and my mentor and Dr. Verma, who was the doyen of inborn errors of metabolism, and my late husband, and also the Intas company for providing the drug free of cost. So I will end with this. This was Sir Archibald Garrett who discovered Alkaptonuria, and he said that it is not merely a curiosity but a key to understanding the chemistry of life itself. Thank you.